Well, that is probably the nicest thing anybody could say to me. So thank you, Michael. That's very, very sweet. This is my kind of silly title. But, I actually, realizing that the previous talk before me was going to be an expert talk on PET and neuroimaging, I decided that I would try to focus a little bit on some projects that we've been doing that are not necessarily focused on those methods, but I think are very complementary. So I have no disclosures. And I'm going to very briefly talk about the neuropathogenesis of acute COVID, because I think that's important to try to think about the pathogenesis of long COVID in the nervous system. And then I'm going to talk about two studies that I am involved with, both of which are looking at the effects of COVID-19 in the brain, specifically on the nervous system. And then I'm going to just end with a few kind of random thoughts that I formed through this conference that I think are important probably for answering these kinds of questions. So I first got interested in this field in March of 2020. New Haven, Connecticut is about 2 hours away from New York City. And when we saw this massive wave of cases that was coming towards the East Coast of the United States, we got all ready, and we had an overflowing hospital full of COVID patients, the same as most people around the world. And what we ended up finding out was that small numbers of people, but very distinct cases of people, had specific neurologic complications. And some of these patients were actually presenting initially with a neurologic complication and later getting diagnosed with COVID when we weren't testing everybody on admission. And so we quickly set up an actually dedicated consult service, and I was the primary person running the service, and I worked with somebody who was a fantastic resident. She's now my colleague, Lindsay McAlpine, and we ended up seeing a lot of these patients. We saw every single patient that was contacted for a neurology consult who had COVID-19 in the hospital. And this is just a snapshot of the kind of cases that we saw for the first 100 cases. And I'll tell you that I was pretty confident that I would be able to be a pretty good investigator and a pretty good clinician for this acute virus in the nervous system. Because in fact, in HIV, my really favorite topic and my most expert topic is actually the effect of acute infection and early infection on the pathogenesis and establishment of HIV reservoirs. But what we found out that actually was acute COVID-19 in the nervous system was very different. And one of the key things is not only did we see a lot of sort of inflammatory-looking conditions that turned out to mostly be kind of immune-mediated conditions, a lot of sort of post-infectious immune condition type of syndromes, but we also saw a lot of cerebrovascular injury. And so quickly I was humbled, and I'm just going to run through very quickly what we've learned over the years about the neuropathogenesis of acute HIV, another RNA virus, but of course a retrovirus, and how different that is in some cases to acute SARS-CoV-2. So a lot of immune activation is induced in both cases in terms of cytokines and cytokine storm, which you also can detect in the CNS. And in both cases, you can actually see a compartmentalized cytokine response that's pretty specific in the CNS and different than the blood. In acute HIV, you have a huge influx of T cells and monocytes into the CNS. And you really don't seem to see this very much in acute SARS-CoV-2. And I'm saying that based both on cerebrospinal fluid studies, where we can readily detect immune cells trafficking in the CSF and HIV and not in SARS-CoV-2, but actually also based on autopsy studies, which are extreme cases. So obviously people who died of autopsy, had autopsy, died of acute COVID, had very severe disease. But even those patients don't seem to have a massive influx of T cells into the CNS. A little bit of autoimmunity in some rare cases with acute HIV. We occasionally see Guillain-Barré syndrome or a facial droop or optic neuritis in acute HIV. Much, much, much more common in acute SARS-CoV-2, and that's obviously been a really important part of the long-term disease. Very little acute cerebrovascular injury in acute HIV, but very significant in SARS-CoV-2. We saw a lot of people who presented with first-time strokes who didn't have a lot of other stroke risk factors. Neuronal injury is detected in both conditions, and there are many, many different kinds of studies with different biomarkers that have shown this. And significant viral invasion into the CNS, readily detectable in acute HIV, viral loads up to the 1 million copies in the first couple of weeks of infection, and really, really no detectable viral load in the CSF in SARS-CoV-2. And on autopsy studies, I think very, very limited detection of virus. And there have been a lot of intensive studies, and some have found some viral proteins, a little bit of viral RNA, but really, really very, very unremarkable compared to the degree, for example, of microglial activation. So based on the work that many people did, Avinath and I wrote this review that sort of summarized the main hypotheses here, that we were seeing a lot of generalized neuroinflammation. We saw a lot of antibody production and some antibodies to SARS-CoV-2 and autoantibodies, limited presence of the virus, either spike protein or viral particles, endotheliitis, which is obviously now being recognized throughout the body in acute infection, and also neuronal injury, which we didn't really understand the mechanisms for. So again, I thought, okay, now we understand a lot about the neuropathogenesis of acute SARS-CoV-2, and it felt like we had some good handle on that. And I'm just bringing this slide up to point out that I heard many times yesterday that very few neurologists have been interested in long COVID. And I wanted to say that this was an article that I wrote with another neurologist in 2020, where we talked about the fact that we were really knowing a lot about acute COVID, but we were starting to see these cases of people who had difficulty with concentration, finding words, completing complicated tasks. And in fact, what we wrote in our article, and at that time 100 million people worldwide, we said how the disease affects the brain might be the neurologic research question of our time. So I just want to say that there really are people who believe this is a really important question, and I think that we need to encourage other neurologists to think that. So then, of course, we were humbled to realize that we do not know the neuropathogenesis of long COVID. And this is a schematic that's based on a lot of the same kinds of hypotheses of what we saw in acute COVID-19, wondering whether these are going to be simply sort of persistent conditions that we are still seeing in long COVID. And trying to answer these questions takes a lot of different types of approaches. Some approaches are accomplished by things like PET imaging. Some approaches, unfortunately, can only be looked at by animal models, however imperfect, or by autopsy studies. But I spent my career doing studies in live human patients. And so we decided that we wanted to set up a study that was paralleling a lot of the other kinds of studies that were being set up worldwide to study long COVID, but specifically to study the central nervous system, and trying to answer this variety of different types of questions using different approaches. So we set up what we called the COVID Mind study. And this is a study that uses different modalities. We are getting 3T MRI of brain, using a variety of different modalities with that. Collecting blood, of course, as everyone does. We collect cerebrospinal fluid, which has been a hallmark of most of our studies that we've done over the years. And then very detailed neuropsychiatric batteries, and of course, very, very intensive sort of phenotyping of these individuals so we really understand who they are. And we're really focusing the study on people who have neuropsychiatric and primarily cognitive problems with long COVID. This is co-directed by Lindsay McAlpine, who's now my colleague, who was my resident previously, and Shelley Farhadian, who's also an infectious disease doctor at Yale. Lindsay's a neurologist. And then we have this dream team of a lot of different investigators. Many of these people are people that I knew from the HIV field who were interested, but also others have been brought in, including experts in neuroimaging, in viral persistence, immunology, et cetera. And what I'm going to talk about mostly today are the cerebrospinal fluid studies, because I think these are the most unique in the field in terms of some of the kinds of things that we can learn by directly sampling CNS tissue in a condition that many, many patients have primarily or most severely CNS complaints and conditions. So the study design for this study is that we have a neuro-long COVID clinic. It's run by my colleague, Lindsay McAlpine. We started it together. She's the dedicated neurologist for a comprehensive care clinic. So she really deeply phenotypes these individuals in clinic, and she refers them to our studies. We've also, for years, screened people from the community for different kinds of neurologic studies. And so we're identifying people that way as well. We have 3 different groups. We have the neuro-long COVID group. Again, these are people mostly with cognitive impairment. We have pre-pandemic controls that are people who we had enrolled for other reasons. So we originally were looking at some of the comparisons there. And now most of our focus is looking at the post-COVID recovered controls. At this point, we have 62 of the neuro-long COVID participants and 45 of the post-COVID who have done all the procedures. And we collect these different things, including the large volume lumbar puncture and brain MRI. And this is a longitudinal study. It was designed to have follow-up for 2 years. We're hoping to get funding to continue this study, of course. And we are planning to enroll up to 100 per group. This is just a snapshot of the demographics of the individuals who have neuro-long COVID and those who are post-COVID recovered, which I think, again, are the most important control group. And we have some demographic differences at this point. We have more women in the neuro-long COVID group, and we have more white people in the long COVID group, so those are still things that we're working on, but otherwise there's some similarity. Most important factors here is that we first assessed people about a year after they had acute COVID-19. And most of the people in the beginning of the study weren't vaccinated. We now have a lot of vaccinated people, so we haven't yet sort of assessed the effect of vaccination. And the vast majority of these individuals convalesced at home, 84%, only 2 had ICU care. So I'm going to mostly focus on the CSF, as I mentioned. And we first look at basic clinical markers, and this is something that probably every provider knows who's ever ordered an LP on somebody with long COVID, is that the basic labs, things like CSF white cell count, protein, albumin ratio, which is a marker of blood-brain barrier breakdown, these are normal these are similar. There's no difference between people who've never had COVID, people who have had COVID and recovered, and people with long COVID in these markers, which is frustrating for patients. We've also done a small but fairly intensive inflammatory cytokine panel. And I'll tell you that based on everything that we knew about acute COVID, everything that I know about HIV, everything that we were hearing from our patients and our participants, I completely expected some of these cytokines to be abnormal, especially also since that's, of course, seen in the blood. But in this panel, and we only have 37 in the long COVID group and 22 in the control group at this point, we have absolutely no differences between any of these cytokines. This is, of course, a small panel, but this is a panel that includes many of the cytokines that we typically see in neuroinflammation, including in people with well-treated suppressed HIV infection. So we were quite surprised not to see any abnormalities. We are now running a very, very large O-link proteomics panel on these same samples, and actually all of the 65 that we have now, to try to see whether or not there are more subtle differences that we're missing simply by looking at these more basic markers. And also, of course, to look for different pathways and patterns. The other thing that's been very interesting is that we've started to look at the cells of the spinal fluid, which is something that we've really been looking at using single-cell RNA sequencing and epigenetics and flow cytometry and those kinds of things. And we're actually starting to see some interesting epigenetic signatures, particularly in the monocytes in the CSF. So there's more to come on that, but I think that that may be somewhere we actually find some signal in the cells, even though we're not seeing them in these soluble markers. But this was quite disappointing, and I'll say whenever I've presented this, any patients in the audience have always been shocked and a little bit unhappy because they think something's wrong and you're not picking it up. The other question is there active neuronal injury? So I mentioned that during acute COVID-19, as well as in acute HIV and many other acute infections, you can see breakdown of neurons by looking at proteins in the spinal fluid. You can see activation of microglial cells by different microglial markers. And what was really interesting here is that we assume that we may still have some ongoing microglial activation, or we may have some neuronal injury. And based on this, again, small number of samples, we really see absolutely no difference between, and we're not comparing here to people with COVID and recovered. In this case, we're looking at pre-pandemic control, so as normal as you can get. And we're not seeing any differences between people who have long COVID and these markers. The one thing we are seeing differences in is something called GFAP. Glial fibrillary acid protein is actually something that is released by activated astrocytes. And what's interesting, actually, is that TSPO, which is the marker that was described in the previous talk, is not only a marker of activated microglia, but it's also a marker of activated astrocytes. And so in this case, we didn't see our microglial markers, which are STREM2 and neopterin, as being elevated, but we do see astrocyte activation or abnormality. You can also see this in the blood, and I know I spoke with someone yesterday who said they've also found this in the blood in their long COVID patients. So because of this astrocyte finding, we've started to explore more about astrocytes, of course, and one of the things we've recently done is looking at astrocyte-derived exosomes. So you can isolate exosomes, particles in the blood and the spinal fluid, and you can identify certain proteins on the surface of these exosomes that indicate they're coming from astrocytes. And we did this with a very preliminary, this is a little pilot study we did with just 6 neural long COVID samples compared to post-COVID recovered. And this is basically a heat map showing some of the differences in microRNA signatures that were detected in these astrocytes. And again, this is very preliminary. I'm a little nervous about people taking pictures of this because I'm not making any major statements. You can, it's fine. But I think what's interesting is you can clearly see a difference in some of the signals here, and some of the upregulated pathways relate to angiogenesis, interleukin signaling, Rint signaling, et cetera. So this is obviously something to be following up and looking more at astrocytes and using some more kind of sophisticated techniques. But I think interesting. So how about antibodies in the CSF? I mentioned that in acute COVID-19, there are antibodies detected against spike, and actually some of these have different epitopes than the antibodies in the blood. There's also autoantibodies that can be detected in acute COVID-19 in the CNS that actually sometimes cause autoimmune conditions. What we find in the CSF, these are all with people with long COVID. Many people had detectable anti-spike antibody in the CSF, and the x-axis here is days from their initial positive PCR test. And actually, many people also have anti-nucleocapsid antibody in the CSF. But the patterns of these antibodies absolutely 100% reflect the patterns in the blood. So they do not seem to have any unique patterns, and it looks like it's really diffusing antibodies from the blood in these cases. So what about, if there's antibodies, antiviral antibodies, what about autoimmunity? And I'll say that 2 years ago, we got very excited about the concept of autoimmunity causing long COVID neurologic symptoms, because we had an interesting patient who was a 30-year-old man with absolutely no psychiatric history, who developed a subacute but pretty abrupt onset of psychosis about a month and a half, 2 months after having COVID-19. We couldn't find anything wrong with him clinically in terms of his lumbar puncture or his MRI, but just because of the timing and the onset and the unusual nature of it, we treated him with IVIG, and it was absolutely miraculous. Oh, also, he had been treated with antipsychotics with absolutely no effect. And with IVIG, he was better in about 4 days, and he was absolutely back to work and completely normal. So we ended up sending his CSF to colleagues at UCSF who have a sort of discovery assay, a way to detect novel autoantibodies that identify neuronal targets. And we found a novel anti-neuronal antibody in the CSF. You can't see the slide at all, but it's showing a pre-pandemic control versus post-COVID psychosis. And the post-COVID psychosis, you can see a lot of bright green uptake, which is the responsiveness. But more recently, and I don't want to talk too much about it because it's going to be presented at CROI this year, we did a much larger survey of these autoantibodies using the same methods. And I'll say that between post-COVID recovered and long COVID, we basically see no differences. We see a lot of autoantibody recognition. So there's either something unusual or strange about the assay, but this is a group that's been doing this for many years and has lots of other totally negative controls, or it's telling us that a lot of people with COVID have autoantibodies that have the potential to recognize brain tissue, even if they don't have symptoms. How about antigen persistence or viral persistence? It's very difficult to test this in CSF with current methods, but we have looked with nucleocapsid antigen measured by the Quanterix Simoa assay and have not found any evidence of this. We've also checked by PCR in people with long COVID. People with acute COVID do have some detection, and that's been shown by another study in Sweden. That's on the far left. But in 31 people with neuro-long COVID and 8 people who recovered, we have absolutely no detection. We have found these same kinds of acute phase protein and coagulopathy marker abnormalities that many other people have found in the blood. So these are plasma measures. And what's interesting here is that we actually have a comparison with people who had acute COVID who were hospitalized, shown in red, people who have long neuropsych COVID in yellow, and then post-COVID recovered participants in blue. And you can see that in many cases, the long COVID are sort of halfway between the post-COVID recovered and the acute COVID. And again, the acute COVID were hospitalized patients, and long COVID recovered were mostly healthy, pretty healthy. What's interesting too is that there are significant differences between a couple of these markers between the long COVID and post-COVID recovered. And this is also true in these inflammatory cardiovascular disease-related proteins that are associated with atherosclerosis. So 2 interesting things here is that actually the pattern for a couple of these markers is that they actually are higher in the long COVID participants quite dramatically than they are in either the severe acute COVID or in the post-COVID recovered, suggested that maybe there's a different kind of process that's evolving in these individuals that's really making them distinct. And finally, there are these endotheliopathy and platelet activation markers, which have been recognized by many people. Again, we're finding are persistently elevated in the long COVID, and in many ways look as if they're sort of resolving from the acute COVID period. One of the things we've been able to do since we're doing detailed neuropsych testing is we've been able to look at statistical correlations between some of the levels of these markers and some of the cognitive domains that we're finding problems in. And it's specifically verbal learning seems to have a lot of association with several of these different kinds of markers, suggesting that they may really have a clinical association with the long COVID symptoms. But again, more is to come on this. I'm not going to talk about this work, really. This is Lindsay McAlpine has a new NIH Career Development Award really focused on neuroimaging, but I just want to show you that she's looking at issues such as brain atrophy. She's looking at integrity of white matter tracts with diffusion tensor imaging. She's looking at regional brain perfusion, which is basically looking at cerebral blood flow, but using MRI rather than looking at perfusion by other means. She's finding preliminary findings in all of these areas that are consistent with other findings. The other thing that she's very interested in is she's developing with colleagues in Paris, actually, imaging of the lymphatic and glymphatic system of the brain to try to understand whether some of the vascular changes that she's seeing in other kinds of structural markers are also associated with lymphatic and inflammatory drainage. So more to come from Lindsay, and she's actually presenting this at CROI this year as well. So from our COVID Mind study, what have we concluded so far? We have now found any evidence for a significant role of autoantibodies in the CNS. We also haven't found any evidence of CNS viral persistence. We really didn't find, and I didn't mention this on the slide, we didn't find any markers of hypercoagulability to be abnormal in our long COVID people compared to post-COVID recovered, but we are finding endothelial activation and blood flow alterations. We are not finding active neuronal injury, so we're not finding that the neurons are still being damaged during this time of long COVID, but we are finding astrocyte dysfunction and some structural and functional changes in the brain. And finally, we're really not finding increased CNS cytokines or activation of microglia, which were two of the primary hypotheses that we had looking into this. But we are potentially seeing some differences in cell state changes. So I think that I'm going to go at the end to talk about some final questions that are raised by the study, but I really quickly want to mention another study that we're doing because particularly it's a unique, I think very sensitive and susceptible patient community that I'm very concerned about in terms of the CNS. So we know that people who are living with HIV have immune activation in the brain, even when they're on consistent antiretroviral therapy, and they sometimes have ongoing neuronal injury. And many people, especially as they're aging, are experiencing some neurologic deficits. And so we wondered whether people who are living with stable treated HIV would have sort of second hit in the brain with inflammation and injury in the setting of acute SARS-CoV-2. And we were very lucky that actually we had a study ongoing where we could replicate in some manners this design of the UK Biobank study. So we've had a long-term, going on for over 15 years, study of individuals in Thailand who are recruited during acute HIV infection, start on immediate antiretroviral therapy, and are now followed for up to 20 years. From the very beginning of the study, we've embedded longitudinal MRI and CSF collection over time in this cohort. So we have pre-MRI and LP information as well as cognitive information in these individuals over time. So what we were able to do was set up a study where we could take samples and data from individuals in this study before COVID-19 and then examine longitudinally after 1 and 2 years what the findings were after COVID-19. I know I'm running out of time, so I will try to go quickly here. We don't have too much long COVID in this cohort so far. About 7% of people seem to meet the criteria for long COVID after 1 year. But we are seeing some interesting findings. Most surprising to me, actually, we were thinking about mostly neurologic findings. We're actually seeing immunologic findings in the cohort. So this is looking at CD4 T cell count, CD8 T cell count, and CD4 CD8 ratio over time. And you can see that actually at 6 and 9 months post-COVID, CD4 counts are lower. And the CD4 CD8 counts are also significantly lower in the people who after they acquired COVID compared to before. Again, there are lots of other things happening at this time point, so we're also comparing to contemporaneous controls. But this is an interesting and concerning finding. And we found a hint of also some cognitive impairment, but that seems to be recovering after COVID-19. And so this is obviously something we're following up. We initially assumed we'd have 150 people in the cohort who had COVID out of 700. We now have about 550. So we really have robust numbers to do these studies. And we're lucky that we also have already some analysis of the MRI findings. So we've had 50 people who've had an MRI before and after COVID, and compared them to 16 people who were longitudinally scanned at the same time frames before the COVID pandemic. And this is a very simple figure, but it's basically recapitulating the findings of the UK Biobank, which is that in the people who acquired COVID, these are not necessarily people with symptoms. Very few people have long COVID, but we are seeing reductions in brain volumes in numbers of brain regions. And this is only in a small number of people, so when we get to about 500 people, we should really have more power. So I'm going to end just a couple of observations. We and others are not detecting neuroinflammation in the spinal fluid. This has clearly been reported in PET studies. I will say that I think most of the PET studies that have used TSPO, to my knowledge, are comparing people to people who never had COVID, pre-pandemic controls. So I think that's going to be a really important thing that we start doing, is really using controls, because now we've seen from Irini's data that everyone who's had COVID has had some kind of change of their immune system. We may not be looking hard enough. We're going to do larger panels to look for inflammation and to try to understand those pathways. We may be missing subtle cellular changes. So doing things like single-cell RNA sequencing and doing epigenetic studies and these kinds of things may actually be more revealing than just looking at cytokines, which are easier to do. And also, we'd really like to synergize these kinds of PET studies with these kinds of CSF studies and neuroimaging studies with functional PET studies that can actually really help us understand those things. And these are some of the ways that we should all be working together and sharing samples and data. The other thing that's interesting, I think, is this detection of autoantibody question. This is something that's obviously reported in a lot of different, we heard about this several times during talks today. If we're having neurologic symptoms, I would definitely expect to be having specific autoantibodies in the CNS, if it's really an autoantibody disease. And so I think one of the questions is, are there specific autoantibodies that are really specific for long COVID symptoms in the brain? Those are just a couple of questions. I'm happy to discuss more afterwards. Viral persistence has only been convincingly identified in tissues. Brain autopsy tissues, and I will, this is in response to Dr. Bomcel's talk, have mostly been looked at in people with severe COVID who eventually died from their severe COVID. We do not have great brain autopsy tissue in people who had long COVID and did not have a lot of other complications and died. So I think that's going to be really, really important to understand more about the significance of viral persistence for long COVID symptoms. Vascular inflammation may be tied to some astrocyte activation because astrocytes line the endothelial lining of the blood-brain barrier. So this is something that I think we should be tying together. How do we study that best? And of course, the long-term follow-up question is a key question for all of us in this audience. How are we going to affect that, make that happen? And I'm particularly interested, of course, in neurodegeneration and long-term effects of COVID in the brain. So I'm sorry I ran over so far. Thank you so much to all of you. Thanks to the study participants. Those are the thank yous for the COVID Mind study and also the Thailand studies. Thank you.